So to set the stage for the discussion today, and what do we mean, it's sort of to define what is artificial intelligence. So artificial intelligence is a field of computer science aimed at training computers to perform complex and cognitive tasks which would usually require human intelligence. AI has the potential to enhance the next generation of technology-based approaches to healthcare and support data-driven decisions that improve the health and well-being of people around the world. So today we'll be talking about the use of AI in healthcare and research broadly, with an emphasis on public perspectives and public trust. And I'll now use my moderator privileges to ask the first question of our panelists. And after that, we'll leave the majority of the questions up to you. So we're looking for your participation here, and it's been great so far. I don't anticipate anything other than that as we proceed with this panel. So we'll reserve about 10 minutes at the end of the session for our panelists to share their insights and for things that may not have come up during the session. Please note that this is a bilingual session, so feel free to ask your questions or provide your comments in English or French. So to start off, I'm going to go virtually to Alison. So Alison, can you identify one thing you trust AI to do with health data and in healthcare, and one thing you don't trust with health data in healthcare, according to your experience?
Okay, my pleasure. Thanks a lot, Rob. And sorry I couldn't be with folks in person. To set up my examples, I'm just going to briefly present something I learned from the machine learning researchers at the Vector Institute. And that is to say that good AI, or I would say trustworthy AI, is AI that aligns the task, the data, and the AI method. So with that as background, one thing I trust AI to do is I trust it to power the Medley app, which has been developed by Heather Ross and Joe Cafazzo at UHN. And what it is it's an at-home app for monitoring for people with congestive heart failure. And the reason it works is because people enter their data into the app, and then the machine learning processes that data in real time and can pick out patterns that humans might not be able to, either because they're slow moving or complex or intertwined, and it can provide a recommendation as to whether that person might need to change their medication or see a healthcare professional quickly. So I trust the Medley app to do that. An example that I do not yet trust is the use of computer vision for detection of skin cancer. And again, it goes back to the task, the method, and the data. And there's no question that AI does great things when it comes to computer vision, when it comes to recognizing, for example, or even creating deep fakes. But the issue with detection of skin cancer is that almost all the data that have been used to train these systems are data for people with light-colored skin. So if my skin were dark or my skin were tanned, I would not trust that AI app alone to tell me whether I needed to be seen by a health professional or whether, in fact, what it was looking at was benign and unlikely to be skin cancer. Those are my two examples.
Fantastic. Thank you, Alison. So next, let's go to Andrew. Andrew, same question, 3 minutes. Can you identify one thing you trust AI to do in health data in healthcare, and one thing you don't trust AI in both of those fields?
Thanks so much, and really appreciate the invitation to be on this panel. And just to be here today, it's been really great to learn from many folks here. And just as a bit of context, I'm a working, practicing family physician and also run a research team, and we do a lot of work with AI, but I'm not myself a data scientist. I work with fantastic teams of folks who help with that. The one area that I would say I would trust AI, and I'm going to put a caveat on this because I actually wouldn't give unwavering trust to any AI, and I think probably everyone here in the room and my fellow panelists would agree with this, without the appropriate controls on that. So trust only if, for example, there is assurances around things like privacy, ownership of the data, sovereignty around it for Indigenous communities, and many other things that we've talked about today. But one area I would actually trust is around the very practical thing around administrative tasks that are required and a huge burden within the healthcare system, particularly within primary care. So we have a primary care system that's under enormous strain. Part of that is because of the administrative burden that has greatly accelerated over the past 5 to 10 years. And this was actually the #1 issue and area for AI application that we identified through talking with patients and primary care providers, was help us with this administrative burden. So that's part of why it's kind of my #1 area. And what do I mean by that? It means things like helping with everything from scheduling people quickly to open spots, to helping with forms that need to be completed, to referrals to the best provider with the shortest wait time, all of those types of tasks. One area I wouldn't trust AI tool, and this is a bit based on the evidence that's emerged, is around a completely autonomous counseling bot. So something that has no human in the loop, is not only about triaging, but is actually providing counseling in the form of an AI chatbot. I wouldn't trust that. I think there's actually good evidence about real concerns about where these bots have actually directed people. And so I don't think they're anywhere near. I also think there's a fundamental concern with these types of tools where they're fully replacing a human. That was kind of identified in some of the discussion today. But also there's an impact of this type of bot on the workforce too. What happens to job security for people in the health sector when their jobs are fully replaced by a tool? We haven't yet, considered that. So that's another reason I wouldn't trust that type of technology.
That's great, Andrew. Thanks a lot. I don't think I trust those chatbots either, especially in that field where it's so critical. So Cécile, over to you. Same question and 3 minutes to answer. What do you trust about AI in health? What is it capable of doing? And what don't you trust AI to do in the health or research fields? Health research.
Merci beaucoup. Alors, je vais répondre en français pour vraiment créer le bilinguisme en réel. Alors, moi, comme Andrew, j'allais parler des tâches administratives, car au quotidien, j'essaie de soutenir les chercheurs dans l'optimisation, on va dire, l'automatisation de certaines tâches. Et c'est là que je vois beaucoup de promesses. Je dois dire que j'ai, comme les IA, un grand biais. Je suis une super utilisatrice de l'intelligence artificielle générative. Et c'est là que je vois beaucoup de promesses pour, comme disait Andrew justement, aller désalourdir le poids de l'administration dans toutes les tâches qu'on fait. Puis je vous dis très concrètement, quand on va voir une équipe de recherche, en santé en particulier, il y a une énorme partie de leur tâche qui est vraiment une perte de temps. Ils le disent, on ne se concentre pas sur la recherche, on doit écrire énormément de lettres de soutien, on doit faire énormément de paperasse, de lecture, etc. Donc là où je vois de la promesse, c'est dans la gestion de l'information. Il me semble qu'avec l'IA générative, on peut gagner un temps fou à aller gérer toutes ces tonnes d'articles, de publications, de savoir qui émergent en continu. Puis là, il y a beaucoup de promesses. Je les ressens très personnellement. Je peux vous dire des applications qui permettent d'avoir des alertes sur de la publication scientifique, d'aller suivre des thématiques, d'aller voir justement ce que des panélistes, des chercheurs inspirants vont publier de neuf. C'est là qu'il y a un énorme potentiel. Et pourquoi je le recommanderais? C'est parce qu'il y a beaucoup d'enjeux. Andrew le disait, Alison aussi. Les IA soulèvent des enjeux de confidentialité. Moi, quand je vais aller voir un logiciel pour le recommander à des chercheurs, je peux vous dire il y a très peu de choses qui sont au Canada, au Québec, ou même dans des juridictions où on pourrait contrôler les données. Ça vient beaucoup des États-Unis et de Chine. Donc, que faire avec ça? Pas rentrer de données confidentielles, c'est-à-dire pour l'instant pour la santé. Si je voulais conseiller, par exemple, à un professionnel de santé d'utiliser une IA générative pour gagner du temps, je ne vais pas pouvoir, parce que franchement, il y a énormément d'enjeux avec la confidentialité des données, la souveraineté, l'emplacement, etc. Alors, en quoi je n'ai pas confiance en l'IA pour faire des tâches dans le domaine de la santé? Il me semble que c'est sur l'évaluation. Aujourd'hui, on voit que quand on travaille avec une IA générative, on a toujours la question, où est-ce que je m'arrête et où est-ce que mon expertise me permet de contrôler le résultat? Et puis, à un moment, on va y aller là, très rapidement. On va automatiser, on va remplacer des tâches les unes après les autres. Puis après, on va se dire, ah, ça, on ne pensait pas pouvoir le remplacer. Mais finalement, l'IA est très, très bonne et même meilleure que nous. Mais il y a un moment où il va falloir s'arrêter, c'est qui évalue la personne qui travaille. Et si on met des intelligences artificielles pour contrôler d'autres intelligences artificielles, comme d'autres en rêveraient, dans les fabriques, c'est comme ça que ça fonctionne, c'est là que va s'introduire le vrai biais. Le contrôle humain, c'est très concret. Ça commence, vous, avec ChatGPT. Lorsque vous questionnez le résultat, lorsque vous lui demandez de citer ses sources, ça, il faut le mettre à l'échelle. Comment on va aller évaluer le résultat des intelligences artificielles qu'on va mettre pour aller automatiser des tâches. Donc, c'est vraiment là que j'aurais des réserves quant à la confiance qu'on peut accorder dans l'intelligence artificielle.
Thank you very much, Cécile. So great sort of perspective shared by these three speakers. And now questions over to the audience and our folks online. So if those questions are forthcoming, let's begin. So anything in the audience that folks would like to ask, or anything coming in online? So yeah, you can enter them through Slido. Oh, there's a couple actually. So here, we're going to start in person. So I'm not sure who was up first. We're just going to wait for the microphone so everybody online can hear as well. Thanks.
Hi there. I was just wondering, would you trust AI to create policies in various areas?
I can start with that. I think the last couple of years with large language models has really helped with being able to quickly sift through vast amounts of text data. So I think one area which is already being helping our colleagues in law is to rapidly, be able to synthesize a huge amount of text data in the form of legal briefs and areas. So to answer your question, I would find it very useful actually to be able to quickly look through existing policies that govern, say, for example, data or in other contexts, and summarize that and bring that together for someone who's then creating a policy. But I wouldn't rely on it to fully write a policy. But I think it's trying to lean into the strengths of these new technologies without causing harm. And also recognizing the biases. So for example, that sort of approach where you say plug into something like ChatGPT or something similar, summarize policies that protect personal health information at the municipal level that's collected. That there are limits to that. For example, it probably wouldn't be able to draw on text that's in other languages or in contexts where they haven't digitized the policies. So you'd be missing all this other work. But I think if you're aware of those limits, then it could be a useful tool.
Thanks, Andrew, and thanks for the question. Any other questions online? If you like, please enter those on Slido. Right now, it doesn't look like there's any coming in. Oh, there is one, actually. So it's, I think that you answered what you would trust for AI in the current context, given what we know. So are there areas where you would like to see AI development? So anyone feel comfortable answering that? Maybe Cécile?
I was passing the stick to Alison actually, but je peux essayer. Je trouve que la question elle est très bien formulée parce que quand vous m'avez posé la question de la confiance, je me disais que ça évolue tellement rapidement que les choses qu'on pensait qui étaient impossibles pour l'intelligence artificielle le deviennent. Et donc, qu'est-ce que ça veut dire de notre confiance? Est-ce qu'on aurait davantage confiance actuellement parce que c'est possible de le faire? Là, il y a des choix de société. Après, pour la question des zones et des applications, je me tourne vers Alison. Je pense qu'elle est beaucoup plus proche de la recherche telle qu'elle est faite en intelligence artificielle.
Sure, by all means. Alison, go ahead. You can give your perspective.
Sure. So the short answer is there are many things that I would trust AI to do, and there are some things that I think AI will be able to do better than humans can do. So I want to make that clear because I understand why people go to administrative tasks, and I see the potential benefits of that, but I would hate for that to constrain our ideas about what's possible. Because one of the things AI can do in general is it can monitor data in real time and pick up complex patterns that humans would not be able to pick up. So a great example of this, I don't know if anyone's going to move to implement it really quickly, but at McMaster, people have used AI to determine when someone's going to come out of a coma. So absolutely no risk. It doesn't affect when they come out of a coma, but if they know when someone's going to come out of a coma, they can tell because they shoot a wave to their head, not like a a beam, like an outer space beam, but they send in a signal, and based on the response from the brain waves, they can tell how close that person is to consciousness. So humans cannot do that. We can look at the person. We're never going to monitor every single piece of data about that person in real time. And that's the kind of thing that if we focus on specific tasks and we make sure we've got the data and we make sure that our method that we're using is appropriate for them, then there are many, many things that we can do. In terms of primary care, one thing that I'd really like to see developed more, because it's definitely there in terms of potential, but it's a bit high stakes, is I would love to get to the point that people could leave an appointment with their primary care provider with complete notes of what was said. Because we all know that if you're in one of those meetings and maybe you're getting some news that's bad or upsetting, you may not process it all, or maybe you have a language difficulty. However, I can also appreciate, we only need to look at, for example, automated closed captioning that happens with some of these meeting tools that we use. They don't always get it right. And if they happen to get, the dose of a drug wrong or something, it could be catastrophic. So I don't tend to think about it in terms of all of AI and all of healthcare. I really like to think about specific tasks where we have the data, we know we're not using all the data, and we know there are things that computer models can do in ways that are better than humans could ever do them. And there are many of them. I've just given a few examples here. So I hope that answered the question and explains why I'm not just focused on the administrative, I'm thinking more broadly than that.
Thank you, Alison. Cécile, did you have one more thing to add?
Juste pour ajouter rapidement, quand on parlait des tâches administratives, on parle souvent de tâches cléricales en fait. Ça va bien au-delà de l'administration. Ce serait du speech to text. Dans une relation entre un professionnel de santé et un patient, ça peut être très riche pour le professionnel de ne pas avoir à noter, mais d'avoir tout de suite une retranscription de ce qu'il dit. C'était beaucoup demandé à l'époque où je fais mon post-doctorat avec des urgentologues. Ils ne rêvaient que de ça, vraiment, de se concentrer sur la relation plutôt que de devoir écrire, prendre des notes. Mais ce qu'on observe, c'est la difficulté de l'implantation de ce type de technologie. En effet, on arrive, on voudrait avoir une histoire de cas d'un patient, faire remplir des questionnaires, avoir des résumés de notes avant l'interaction. Mais quand vient le moment d'implanter ce type de choses, c'est extrêmement difficile. On connaît les processus qui sont bien agencés, le manque de personnel, etc. Je pense que là, plutôt que de se demander où est-ce qu'on devrait appliquer de l'IA, c'est pour les solutions qui sont prouvées par la littérature, comment on fait pour les appliquer. C'est là qu'il manque la science. Là, et on appelle ça la science de l'implantation. Mais pour l'instant, c'est encore un défi.
Thank you very much, Cécile. Maybe I can just add to that. I think like Alison's point and Cécile and others is I think the use of scribes is already starting to happen, and exactly that idea of creating a summary. In fact, our team at the Upstream Lab is evaluating the implementation of one of these scribes that does this kind of dual creation of note and a summary of a visit, and we should have some results by the end of the summer about this. So I think there's some key things moving ahead. In terms of what else is on the horizon, again, if we proceed in this appropriate way with ensuring things like privacy, that the data is not going to be sold or misused, and that people are aware of it. Some of the other areas where I see it moving into beyond the administrative tasks are prediction. So we're doing work around, could we imagine where a primary care team actually starts their day by seeing a dashboard which tells them, out of your patients, these are the ones who are at greatest risk. And this is where you should be directing your energy in that first kind of half an hour or 40 minutes of your day, and then turn to the people who have booked appointments and things like that. This would start to actually enable teams to make use of all of the data that's available, and also to not just be reactive, responding to people who come in and connect with us. And we're starting to see that it is possible to do that type of prediction. Another area which we're just on the verge of is really the full integration of expert systems into care, where a family physician like myself may only see a few cases in my whole career of a rare disease or a rare circumstance, and may struggle to diagnose something. If we could integrate these expert systems, which would be able to take advantage of the latest evidence, that would be helpful. The third and maybe final area that I are starting to see is, and again, we're doing some work in this area, is pandemic preparedness. Can we be at the, unlike what happened with SARS and also now with COVID, can we be much more prepared for the next pandemic and much more rapid in terms of tracking where it's going and being able to identify that there's a new pattern? I was looking at the kind of history of SARS in Toronto. I was a first-year medical student when it happened, so I have these very vivid memories because it was the start of going to remote learning, of having meetings through teleconference, so you didn't meet in person, so not everybody in the room would get sick, and things like that. But I was looking at the timeline was the cases were spreading in Toronto of SARS after, like way before the WHO declared a pandemic and said there's something really concerning. So we really missed those early warning signs. We now have data which could enable us to detect something is very unusual about a strain or about a set of symptoms and be more prepared. We're not there yet because there's a lot of precursors to get to that. We need full data from charts. We need really excellent de-identification processes. We need the infrastructure to be able to have near real-time data. We also need to ensure that vendors are not putting in barriers to the appropriate use of the data. So there's a bunch of steps, but I think that we're on that route.
Fantastic, thanks. There's a couple of questions yeah, by all means.
As we're talking about this, I'm realizing, and it might be helpful for people to think about 3 broad categories of AI in health. The first is the administrative, like just healthcare should be using AI in the same way other industries use it. So with appropriate protections and confidentiality and privacy and all of these things, and making sure that the data aren't used in ways that people don't agree with. But the scribe would be an example of that. There's no reason on the surface that healthcare shouldn't take advantage of some of these technologies that are already helping other sectors. The other extreme is just sort of hypothesis generation, sort of exploration. So for example, Laura Rosella did some interesting work with people with diabetes that suggested there were more types than the traditional type 1 and type 2 that we think about. Much work has to be done to sort of confirm that that's real and makes sense and what it means clinically. But it's this idea that you could sift through vast amounts of information and patterns would emerge that, again, humans wouldn't detect. And then the third category is probably the one people are the most interested in. It's, we have all kinds of data, not because we set out to create all kinds of data, largely because we moved away from paper systems. And Michael Shull used to say that's like exhaust coming off a car. Maybe he even said it at this conference. And the thing is, with AI, we have the potential now to make use of that data in some way. And that doesn't mean that everything's going to work. Some of the experiments, if they're not done thoughtfully, they're not going to lead meaningful results, and they can even do harm. But it's sort of those general 3 categories, and all, I think, should be on the table when we consider what kinds of AI we want to support.
Super. Okay, over to the in-person questions. There's a question at the table here.
And sorry if this is kind of worded, or I've been sort of reflecting on different things as I hear the talks today. And I suppose you guys feel that there's a limit. And when I say that, how do you feel AI is capable of tackling maybe more abstract concepts such as morality and like some more philosophical debates that's not so concrete? Do you think that it will ever get there, and do you think that it should get there? Is my other question.
That's a really interesting question. So for everyone, it was, could we imagine AI tools helping us with, for example, moral decisions or things like that? I think the tools that we have right now are limited in that they can tell us back what is fed into them. So if you wanted them to summarize all of the famous philosophers' work on a topic, like on assisted dying or something like that, it could do something like that, probably at the level of like a undergraduate kind of level, but it certainly can't be the one to make those decisions. And I think that's the great fear, right? I think, which unfortunately is already happening, particularly in other sectors, particularly in other countries, for example, in the US, where they have already, used tools to do really important tasks like sentencing, making decisions about how long someone should be sent to prison, or who gets put in foster care or not, or who has extra surveillance. Like, these are really important decisions, and I think part of, these tools which emerged, about 10 years ago, part of the whole concern with them has been because of that ceding important decision-making to a machine and taking the human out of the loop, or where the human gets too dependent on it. So kind of saying, well, the algorithm said this is the case. A really famous example, which was published in Nature in 2019, was of a large insurance company in the US using a tool that had machine learning built within it to make decisions on which patients should get extra care or not. And it was using purely economic reasons. So do we put more resources to someone after admission because it's going to save us money? And what they found, again, today in 2024, not surprising, that it was heavily racially biased, that it was systematically being biased against Black individuals in terms of resources. And so that was a good example, which was about not keeping the human within the decision making, and also not being aware of how things were working, and the whole point which others have brought up today around algorithmic bias and being aware of it. I think where we need to go is really into what we need immediately is which HDRN I think can play a key role around, is building off all the great work that's been done around patient social license for this type of work, building on that to actually engage provinces and territories to set up processes that make sure communities and patients are consulted and are helping with governing this data, and that communities are aware of. And then quickly moving to a process around Health Canada regulation of these devices. We're in this space right now where these things are somewhere between a device, a true device, or more like a tool or an app that somebody would use. And there needs to be a more clear pathway that also helps accelerate their implementation of these things.
Spectacular. Thanks, Andrew. I think we have to hop back online for the second question, or the next question, I mean online. And so that is, how can we trust the results of generative AIs like ChatGPT when we don't know what data these open source generative AIs have been trained with? Cécile?
Bonne question. Mais la question, c'est est-ce qu'on a besoin de tout savoir pour avoir confiance? La confiance, elle vient justement dans l'ignorance. C'est pour ça qu'on a confiance dans les gens, c'est parce qu'on ne peut pas tout contrôler. Alors si on prend de vue des données, par exemple, pourquoi on demande d'avoir confiance? C'est parce qu'on ne va pas contrôler tout l'usage de nos données. Et donc à un moment, on fait, comme disent les Anglais, un leap of faith, un saut dans le vide, et on a confiance. Par exemple, moi, quand je vais aller voir un praticien, un professionnel de santé, je ne vais pas lui demander de m'expliquer tout son raisonnement déterministe ou son arbre à décision pour qu'après on arrive à un diagnostic différentiel qui va me convaincre. J'ai confiance dans son expertise. Alors la question qui tourne toujours autour de l'IA, c'est si j'arrive pas à expliquer sa prise de décision, est-ce que je peux avoir confiance? Il y a beaucoup de gens en lesquels on a confiance sans vraiment comprendre comment ils réfléchissent. Mais il y a une espèce d'autorité, il y a une légitimité du savoir, il y a une vérification possible par des pairs. C'est ça qu'il faut qu'on mette en place avec l'IA. C'est-à-dire pas besoin de savoir exactement, et peut-être qu'on ne le saura jamais, comment ou sur quelle base de données ou à partir de quels paramètres l'intelligence artificielle nous a fait une recommandation. Mais si on est capable de vérifier et d'aller évaluer si cette recommandation est aussi précise, pertinente et bonne que ne l'aurait fait un être humain ou une autre technologie équivalente, alors on peut avoir confiance. Donc là, il faut un peu déplacer le débat. Puis je ne peux pas m'empêcher de répondre à la question sur la moralité. Parce que c'est très intéressant d'en parler justement à cette table sur la question de la certitude. là, on ne va pas tout mélanger, mais il y a plusieurs types d'intelligence artificielle. On commence à le comprendre avec le très bon exposé d'Alison. Elle disait qu'il y a des IA prédictives, hein, les plus traditionnelles, qu'on utilisait pour faire justement de la prédiction sur le statut d'un patient, s'il va empirer ou s'améliorer. Et là, on arrive dans un champ un peu plus large, là, les modèles de langage, dont l'IA générative. Si je parle de l'IA générative, on en parlait justement, c'est des intelligences artificielles qui, sur le plan de la moralité, elles ne questionnent pas. Je ne sais pas si vous avez regardé, mais quand vous interrogez un outil comme ChatGPT, il ne va pas vous dire « Attendez, j'hésite, je m'interroge, peut-être que c'est ça, mais cette option est aussi possible. » Il va tout de suite, finalement, indiquer une voie, une direction, sans se poser de questions. Or, le point de vue de l'éthique, la moralité, c'est le questionnement, c'est le débat. L'éthique, c'est la pratique de la moralité dans une collectivité. Qu'est-ce que je peux faire? Qu'est-ce que je ne peux pas faire? Quel est le point d'orientation qui me permet d'agir? Et donc, c'est exactement le contraire d'un système d'intelligence artificielle générative qui va asséner une réponse sans questionnement. Donc là, je reviens à la question, est-ce qu'on peut utiliser ce type d'IA pour s'orienter dans la vie, prendre des décisions? Certains diront oui, bien sûr, mais en fait, l'idée, c'est qu'il faut qu'on comprenne comment elle fonctionne, qu'on ait un esprit critique. Et je reviens justement à ce que tu disais, Rob, il faut de l'éducation. Le discernement, il vient justement par l'esprit critique autour de l'outil.
Super, thanks. Excellent, thank you very much, Cécile. We're going to go back to the floor. We have a question ready to go.
Thank you. There was a lot of discussion this morning about social determinants of health and the implications on health. And I'm wondering if AI might not help us with the answers there. If we could create training for doctors to check off certain boxes in those areas as well as the specifics of the physical or mental health, it could spit out some better ideas for them about how to deal with that specific patient, I think. So don't give them a drug that they aren't going to be able to pay for anyways or needs to be kept in a fridge and they're sitting in a homeless shelter. I mean, it's just not going to go. So I think that might be a really good thing. That's what I trust. And what I don't trust is the stewardship. Are we really getting privacy, confidentiality, and security in all the companies that are being hired to do AI?
Well, I'm really happy to take the first part, which is near and dear to my heart because a big part of the Upstream Lab's work over the past 8 or 9 years since we started has been exactly on this issue of the social determinants of health. And it really begins with this premise, which we heard in the morning as well, which is that our health is influenced by all of these other factors, particularly for those in our community who are experiencing the greatest vulnerability. So although we focus a lot of resources and attention on the biological therapies, sometimes the biggest thing are things like housing, food security, income, work conditions, social connection, and things like that. So with the lab, we've been doing a bunch of work on interventions on those types of things, what works and what doesn't, how do we integrate them into the health setting. We've also done work on this topic of data. So we've worked with patient partners and communities to develop a standard way of collecting this data and then implementing it. Melanie Ann Smithland, who's here, who's a postdoc with our lab, but based here in Montreal, has been doing some great work on how do we implement and scale this up. But we've also, one of our previous postdocs, Stephanie Garys, who's in Calgary, did great work on can we derive this type of social data from charts. It's a lot of work to collect it from each individual person. What would it look like if we could derive this using natural language processing? And what we're trying to envision is a system that continually is learning and would always have some folks who are answering the questions, but then be trained and get better using those gold standard, but then be deriving it not to necessarily assign social categories to different people, but rather to paint a rich picture of the whole practice or a whole population, and give decision makers a sense of this is the signal that we're seeing in terms of inequities. So this would be a made up of combination of collected but also derived data to create a whole picture of a whole practice. I work in a family health team that serves 50,000 patients. We have this type of structured data from about a third of them, but for the 2/3 we don't, how do we fill in the picture? I think in terms of your point about also directing resources for a provider, it's really hard for them to know where to direct people. So it's one thing to identify a challenge like food security, but how can I more quickly help this individual patient in front of me with what resources are available? So I think there's a role around that. You know, though, the interesting thing with this is it still comes back to the human, that having that data at my fingertips would help when I have a 15-minute appointment and I need to help them with not only their diabetes, but also their food security and also their social connections. That would help, but ultimately it'll be a human that they trust, where it actually connects. There's been lots of great studies from the US when we just give people, here's a big packet of paperwork, go to this place, go to this, it doesn't tend to work. Again, in the morning, Antoine and Farron, who spoke, they spoke about that idea of getting to know who a person is, and we have to keep that within this work on social determinants as well.
Thank you, Andrew. Let's bring up the online questions again, please. I think I missed the first one. I think it was about distrust of AI in general. So I think you kind of spoke to that a little bit, Cécile. You talked about trust, not distrust, but I mean, so if we want to go to that one, maybe I'll go to Alison to see if she has any perspective on that we can lend quickly, as we're already at 4 o'clock here in Eastern Canada, in Montreal.
Sure. So I don't trust anything. I don't give my blanket trust to anything, you know. I have to know that there's reason to believe that what's being suggested is in fact trustworthy. So that's where I'd go. That's the heart of the matter for me. Do I see AI playing a role in determining morality? No, that is not a task for AI. Is there maybe something that analysis of data with sophisticated methods can contribute to that? Perhaps, you know, historical analyses, et cetera, and similarly, social determinants of health. The idea of trying to construct a complete picture when you don't have one can be helpful, but is AI the solution to improved equity, health equity? No, frankly, it's not. So, but I do want to sort of go a little deeper on this, because the truth is, like, I do calculations with Excel all the time, and if Excel had an error deep within it, I wouldn't know unless it was a really obvious error. So I think maybe I'm a little more focused on some of the potential benefits of AI in health than some of the other folks here are. And I just want to make sure that we move carefully and thoughtfully, focusing on risk mitigation as opposed to complete risk avoidance. Because I do think there are some capabilities of AI in our data-rich world that I personally want to benefit from them. I want my family to benefit from them. I want others to benefit from them. And we got to be alert for the signals that things are not trustworthy. For example, that people are looking to exploit us for our data, monetize our data. We got to be alert to that. But for me, that's not a reason to completely not take it, you know, experiment and learn with consenting people. Because over time, what I see is individual appropriate tasks are going to turn into groups of tasks, which are going to turn into things that have widespread benefits. We wouldn't have, I certainly didn't imagine, you know, this scribe function progressing to the extent it had 5 years ago. And it's going to continue to move quickly, not because people are particularly focused on health, but health sector can benefit from it. So yeah, I hope I answered that. I don't trust anything blindly. I look for something to be trustworthy, but I also realize that if I want to see the benefits, that there's going to be some experimentation, and that happens in all aspects of life, not just with AI.
Thank you, Alison. There was another question on the floor. There's actually quite a few, so which we probably won't get to them all.
Thank you. That's a great presentation. I can tell you that as an, I'm going to say older member of the public, I want to be involved and I want to be at the tables where AI is discussed. I have a very hard time following it. Like, what is it really? And so I'm hoping that all of the people that are working in that field, whether it's an institution, you know, that I deal with, are trying to bring it to us, to explain it to us so that we can be part of the conversation. But my question is, can you talk a little bit about this, the use of AI to spread misinformation?
I can start, and I want to also note that engaging patients and community members is so important at the start, and a few people today have noted that. And it really is very much can be done and should be done. And I think HDRN has done a really great job of engaging people from the very early days. Some of our students, Jillian Macklin and Samira Adas, actually did a fantastic review of how to engage patients in the development of AI for healthcare, and that recently just got published. So there's some great methods and approaches, and it's very, very doable. So anyone who tells you like this is all moving so quickly we can't do that, you know, don't listen to them. In terms of misinformation, the area that comes to mind the most is actually around public health and the public health crises like COVID that we've lived through. There's a huge, you know, we've witnessed a huge increase in misinformation about public health issues that have arisen, in part because social media makes it a lot easier and cheaper for people to spread info. Now combine that with the ability to create very, very realistic video, you know, images and other types of things, and it's a very scary prospect. A lot of our governments around the world are well aware of this and trying to put in place ways to counter these types of things. Many will know that this year, 2024, is one of the biggest in terms of ever in history, the number of democratic elections happening around the world. I think something like 2 billion plus people around the world will be going to the polls. We have evidence in Canada that our elections were subject to misinformation threats. So it's a tough thing, you know, in a time of a public health crisis, we will need to anticipate that there's going to be misinformation. We need to counter that. We need to reinforce, and I know everyone in the room here is very much a proponent of science, but we need to really increase that. And I guess the thing about that is many of us are very, very privileged and come to this as highly educated folks who have, you know, secure positions and things like that. We have to really do more to engage a great diversity of folks within science itself and say, this is something that is actually funded by the whole Canadian public and is something that's going to hopefully benefit everyone. And we need to engage folks from all sectors of society in this, you know, and in this effort to also anticipate those types of threats. The reality is the technology is already out there. Like any one of us can easily create a video now of me or Alison or Cécile or anyone saying something, and it could be very realistic. And that's the scary thing. So it's more about realizing that how do we reinforce trust. One last point is that I direct a primary care research network, and we're really moving to much more grassroots engagement of patients from, you know, small and large primary care teams in helping direct our work. What we want to envision is where 3/4 of the council that approves projects are patients from across all of our sites, and only 1/4 are faculty who are the ones, you know, running the projects. And, you know, trying to do that more to make it very much that it's a product of people and their communities as well.
Spectacular. Alison, did you have something to add?
Yeah, I wanted to say in terms of getting involved, I would really encourage people to not think, you know, AI as broadly as it is, but if you're at this conference, probably you're familiar with the websites of people who run labs like Andrew does. and go for specific projects, because it's what I'm trying to get at here. It's not like there's like this whole thing of AI that you can engage on, but there is, for example, how right does the scribe have to be before you put it into practice, for example. And I think that's where a lot of the actual questions are going to come up. It's not about when you've got the right AI and the right data and the right task, that's okay. But then someone wants to use the data for somebody else, for something else. And then they want to go one step further, et cetera, et cetera. And the sort of scope creep or function creep that can happen. And I think the best way to get involved with that, as I say, is to start with something that you're very interested in and then see where that leads you.
That's fantastic. Thanks. Cécile, please.
Rob, je veux juste ajouter une chose. Je sais qu'il y a beaucoup de questions, mais il y a quand même un problème dans ce pays et dans plusieurs pays. C'est qu'on met des milliards dans les centres de données, dans la recherche. Vous avez vu que les dernières annonces du gouvernement Canada, c'est très bien, là. Yoshua Benjo le demandait, il faut de la souveraineté numérique, c'est formidable. Mais quand on regarde l'argent en proportion qui est investi dans l'information, dans la consultation, dans l'engagement, dans la co-création, on parle de miettes, là. Moi, je suivais à l'époque la plupart des investissements de Scale AI dans l'IA en santé au Québec, à travers la super grappe. C'est-à-dire qu'on avait $1 million pour développer le système d'automatisation du bloc opératoire. Donc déjà, 1 million, on n'en voit pas souvent. Hein. Mais ce n'était même pas assez, hein, d'ailleurs. Hein. Ça passait tous dans le développement, dans des grandes firmes qui développaient avec des gens qui sont très, très bien payés. Puis l'implantation était gratuite, c'est-à-dire le personnel de santé donnait de son temps pour accompagner l'implantation, en croyant aux bénéfices. Il fallait vraiment y croire fort après 2 ans. Et alors, formation, il y avait 0. Donc là, on a un peu évolué. Je pense qu'ils sont en train d'investir un peu. Mais il n'y a rien du tout en termes de littératie des données. On en parlait dans le dernier panel avec Kim Malgrave et Alice Maybe. C'est vraiment rien du tout. Et alors là, pour la littératie de l'intelligence artificielle, c'est-à-dire juste comprendre à quoi ça sert, les risques, les enjeux, sont des gens qui font ça avec des OBNL, des centres de recherche qui donnent de leur temps pour aller informer le public. Donc là, il y a un vrai problème.
Thank you very much. We are fast approaching time. So there was one question on the floor. I'd like to get that in quickly, and then we have to wrap it up. So I'm going to go back to the panelists after this question for a very quick wrap-up, and then we'll wrap up the day, which I'll turn it over back to Bill. So if I can have this question. Oh, I'm sorry.
Thank you. Okay, this might be a bit of an open-ended question, but do you guys worry about healthcare becoming complacent on AI? And how do we mitigate the complacency within relying on AI in healthcare and clinical practice?
I can start. I think when you mean complacency, you mean like that there could be an over-reliance on it, like that people kind of get into a habit of, well, the machine told me so, therefore I will do this. It's a risk. There's a really good, I think, very good example of the benefit, speaking to Alison's point of there is benefit that can be there. The hospital that I work at, St. Mike's Hospital in Toronto, fantastic team led by really great colleagues, Amol Verma and Fahad Razak, are running a project where it's called ChartWatch, where they have a tool which tells internists for their patients who are admitted to general medicine which ones are going to be likely to need the ICU. And it sends a warning signal to the team, and then they can choose to put more care, observe, go to the bedside, order other tests. And in early results, it's really showing that it's actually saving lives, which is really exciting. There is a risk, which the team is well aware of, that you could get where teams rely on that signal, that they're not using their own judgment. And maybe even not paying attention to patients where there isn't that kind of signal saying, hey, go focus your attention. I think that's a risk with almost every signal. I think we always have to keep the human connection into the loop. The hope is that, with these tools, that they actually help us focus our energy where it's needed, but that gives us back more time for the more human aspects of medicine. That would be the ideal. I'm mindful that things we haven't touched on too much are work conditions in health. I think there's always a risk with new technology that there could be some workers who are made worse off and we have to be mindful of that. We have to guard against that. For example, personal support workers whose now jobs are being, or like kind of like an Uber driver, like scheduled in such a way that they don't even have time to go to the washroom, or surveillance of their work, where they're relying on some application actually judging the quality of work, and that could disadvantage people. So we have to be thinking about that, and we also have to remember there could be governments that implement these tools and then use it to save costs. Say, well, we did this, and then we know we can shrink the budget by 10% because it's focusing your attention. So we have to get out of a deficit base. We can't accept that there's just, there isn't just funding. As a society, thankfully, we live in a country which has really held up healthcare as something important, and we need to continue to focus on that and try to expand that.
Thanks, Andrew. I'm going to quickly run over to Alison. She's got something to add.
Yeah, this really does concern me. I don't think many humans would opt to be replaced by tools, but I think especially if the tools are working well, you can just come to depend on them and rely on them and check them less and less and less. And we know, for example, you can get model drift over time. So I'm not aware of this being in place yet, but I think we're going to have to go to some kind of human verification for a lot of these things along the way. I don't know what the frequency will be as part of the implementation plan, but I don't think at any point you just sort of turn it off and trust it. And I think there's a particular concern here because rightfully the private sector, they're the ones taking the risk creating a lot of these apps. It's really not going to be in their interest to show that their model is drifted and isn't working very well anymore. So I think there's going to have to be some rules about that.
Thank you. Cécile, anything to add on this one? And then we'll go to wrap up. You're okay? Okay, so we have about 5 minutes left, so that gives you each about 1:30, so I'll ask you to keep it really tight. So Cécile, if we don't mind, we can start with you, and I'll give you more time. And you can sort of talk about what you've heard today. We covered a lot of ground, including moral decisions, pandemic preparedness, rare diseases, scribes, using AI for scribes. So if you don't mind, just sort of wrapping up what your thoughts are about this session.
Okay. Je vais commencer en disant que j'ai un point de vue de citoyen et que je ne suis pas du tout experte en intelligence artificielle et santé. Donc j'espère m'être exprimée personnellement aujourd'hui. Donc ne prenez tout à la légère. Deuxièmement, j'espère ne pas avoir froisser les juristes avec ce que je vais dire par la suite. Je pense qu'aujourd'hui, il y a énormément de préoccupations autour des données de santé, de l'intelligence artificielle. On l'a senti, beaucoup de questions sur la confiance, je trouve ça passionnant. Mais la réponse que demandent souvent les citoyens, c'est qu'il faut encadrer plus. Il faut encadrer l'IA, il faut encadrer l'utilisation de nos données, il faut protéger notre vie privée, notre confidentialité. Puis on le voit, au niveau fédéral, il y a un projet de loi qui s'appelle C27, avec un grand volet sur l'intelligence artificielle. Puis la loi est essentielle. Mais il faut aussi apprendre de ce qui s'est passé ailleurs. Les gens ont passé des lois sur l'intelligence artificielle, on peut le voir par exemple en Europe, il y a un règlement général. C'est pas ça qui arrête les géants du web ou qui peut arrêter des petites entreprises de développer en fait des rogue systems. D'accord, la loi, bien sûr, elle pose des balises, mais c'est vraiment l'implantation qui importe et c'est la manière dont les gens vont se saisir des principes. Et pourquoi j'arrive là? C'est parce qu'on va avoir les meilleures lois du monde qui vont interdire des systèmes dangereux, certainement dans le système de santé. Mais après, il va falloir mettre des agences, un peu comme on l'a fait avec les dispositifs médicaux, pour s'assurer que réellement, du premier point de l'idée vers le développement et après l'évaluation des impacts, il y a des gens qui regardent, il y a des gens qui mesurent, etc. On le voit avec les médicaments. Des médicaments ont vraiment tué des personnes par milliers. Et comment on s'en est aperçu après? C'est avec des agences de vigilance. Il ne faut pas que ça se passe comme ça pour l'intelligence artificielle. Donc ça, c'est le premier point. Il faut faire de la surveillance. Deuxième point, il faut que les gens se saisissent de ce discours et qu'on arrête de faire penser que l'IA, c'est complexe, que l'IA, c'est finalement hors d'accès ou hors de compréhension de tout un chacun, pour que les gens se disent, OK, il faut que j'aille intervenir, que je donne mon point de vue et qu'il ait un impact. Parce que les dirigeants, parfois, ne sont pas meilleurs sachants, mieux experts que la population sur l'IA. On se rend compte assez facilement, en fait, le savoir, la concret, il vient des personnes. Je vous sors une dernière anecdote. Je donnais une formation dans une bibliothèque publique de Montréal sur l'intelligence artificielle. Puis tout le monde pourrait dire, les gens, ils trouvent ça complexe, ils n'ont pas d'avis. Tout le monde a un avis sur l'intelligence artificielle. Puis les gens ont sorti des choses qu'on trouve seulement depuis récemment dans la littérature. Ils m'ont parlé de l'impact énergétique de l'usage de l'intelligence artificielle, de la manière dont ça rentre en concurrence avec leurs activités actuelles, comme laver la vaisselle. Ça, c'est très concret. Donc, je pense que tout le monde a un avis, mais c'est maintenant aux personnes expertes de laisser un espace public pour qu'on puisse s'exprimer. Merci.
Merci. Andrew, I'll go to you for a very quick wrap-up.
Yeah, just one thank you again for the invitation, and a few final thoughts. I think Alison noted this, and also Cécile in her closing, is we need urgently some form of regulatory body that is going to be doing that third-party evaluation of a tool both at the time of implementation and afterwards, and incorporating within that an equity evaluation that looks at, is this performing the same for all groups? And I think related to that is we always, no matter what the technology is, we have to keep focused on the ultimate goal is this improving health? Is this actually resulting in more health? And is it also reducing inequities? And always keep those two kind of items in mind as part of this, always stepping back from the kind of the brilliance of the tool and the fascination with it, but just, you know, coming back to those basic principles and kind of insisting that governments use those as the metrics for what they're going to support.
Fantastic. Thanks very much, Andrew. Alison, last word to you.
Yeah, so I'm going to pick up on this theme of inequities, and I'm going to say any technology, you know, the automobile, probably the wheel. The first people to take advantage of it are those with resources. So there's always a risk that any new technology is going to grow inequities as opposed to reduce them. So we have to be aware of that, and we have to act on it. And in particular, I want to end by focusing on how communities of people with disability are talking about AI. Because for them, it's not a nice to have. Like the fact that AI does real-time closed captioning, for me, I like it. For them, it can be a game changer in terms of whether they can participate and understand or not. So when we think about ways to involve members of the public, it's really important that we are reaching out to those edges of the population distribution curve and talking to the people who have specific needs and interests that are different from those of the majority, from people like me, and that we focus our AI tasks and figuring out what data we need and how to get it done on those needs, as opposed to just sticking to the center. Because otherwise, there's this natural tendency that we will grow inequities with AI, and that is something we do not want to have happen, particularly because there are things about it that could reduce them.